I'll get started. So my presentation is going to be about how mental health and chronic pain are linked. So chronic pain is defined as pain occurring for more than 3 months despite therapeutic interventions, and it exists on a very broad spectrum of conditions. However, there are general patterns that can be observed in its global effects on an individual. And when I say global effects, I mean like how it affects the person as a whole, both socially and psychologically, not just medically. So patients with chronic pain are more likely to be diagnosed with anxiety and depressive disorders. Yet conversely, having a psychiatric disorder actually increases the chances of being diagnosed with chronic pain. And when I learned about this relationship, I thought it was really interesting and wanted to see if it was because the two were directly linked or not. So that's why for my essay, I explored the relationship between chronic pain and mental health, dividing it into social, psychological, and physical links. So I'll start by giving a brief descriptions about depression and anxiety, because they're the two disorders I've primarily focused on. So the most common psychiatric comorbidity to chronic pain is depression. And I created these little spider diagrams based on NHS guidance, and they show some of the most common signs and symptoms that are associated. Some important symptoms I wanted to highlight are things like avoiding friends and family, unexplained pain, and avoiding hobbies and interests. Depression is generally described as a pervasive low mood, and this is especially important to consider when treating patients with chronic pain, as it can be linked to an increased risk of suicidality. And in anxiety, it's a similar diagram. So some symptoms on here that I would like to highlight are sleep disturbances, feelings of dread, and tiredness. So anxiety is the second most diagnosed psychiatric comorbidity, and it's defined as a feeling of unease or dread in response to a perceived threat. And there are many overlaps in symptoms between anxiety and depression, and because of this, chronic pain tends to be linked to anxiety via the shared symptoms from being diagnosed with depression rather than having a direct relationship. That's something I found interesting. And then to begin with the first link, I wanted to talk about isolation, because when I read personal accounts from people with chronic pain, this was mentioned in pretty much every single one. It was a very common theme, and it was often mentioned that the people around the patient did not truly understand their experience, as they themselves did not have chronic pain, and this made the experience very lonely for the person. And there was also a lack of understanding on how their illness could present. Being capable of doing an activity one day did not mean that they were capable every day. And however, this was difficult for people to fully understand, and they would lose friends as a result. And this burden was added to by mental health comorbidities. People would feel less able to keep up with social activities, and it's harder to be distracted from the pain. So overall, the experience of chronic pain was lonely, yet it also prevented people from going out and socializing. And this links to mental health because isolation is causative of worsened depression and anxiety. Both of these illnesses are very restrictive and also prevent people with chronic pain from socializing. An important thing I learned about was how being distracted helps to reduce the perception of pain. However, being isolated can increase a person's focus on pain intensity, and it creates a sort of like a downward spiral of increasing isolation, worsened mental health, and worsened pain experiences. Next thing I wanted to talk about was a psychological model called the fear avoidance model, and it describes how when normal pain occurs, it directs a person towards that pain to give attention to either like a threat or a site of injury that's currently occurring. So it acts as an alarm, and it's meant to be a safety mechanism to help the person to avoid further injury. However, this can continue to occur in chronic pain, and it can become harmful. When attention is directed towards the pain, the perception of intensity is increased, as well as its impact on the person's daily functioning. constantly feeling endangered can also widen perception of situations that may cause pain, such as moving, and this will lead to further avoidance, and this can be very debilitating and disable the person from functioning normally. This is linked to mental health again, because it's a common symptom seen in both anxiety and depression. Catastrophic thinking is the common symptom. Basically, it's about being short-wired to go straight to the worst possible perception of a scenario, and experiencing catastrophic thinking can escalate the destructive nature of pain and worsen its experience for the person. And then this is a physical link I talk about. It's about ascending and descending, like neurological pathways. So there are lots and lots of different pathways, which I didn't go into the specifics of because it's very complicated, but generally it's divided into like ascending and descending pathways. And the ascending pathway is nociceptive, which means it processes harmful stimuli and identifies the type of pain we're experiencing. However, people with chronic pain may experience allodynia, which is the processing of non-harmful stimuli as causing pain, and it creates a perception of pain where there is no injury. And this may explain why people with the same chronic pain diagnoses experience variations in the type and severity of pain. And then the descending pathways are analgesic, so they determine the body's response to the pain. They tend to involve opioid receptors, which help diminish pain, stress, and emotions. And in some types of chronic pain, these opioid receptors are activated less, thus less inhibition of the pain. And other descending pathways are serotonergic and norepinephrinergic, meaning they involve serotonin and norepinephrine instead of opioids. These are closely related to the opioid system and are involved in the processing of anxiety and pain. Because they are so closely related, it is thought that there may be crossing over and physical links between them. And then I've got this graph here, which I sourced from a paper from 2021 about the physical anatomy of pain and suffering in the brain. And I thought it was very useful because it shows this relationship where when they're equal, there's no pain, but when they become unbalanced, you get perceptions of pain where there might be no injury. And next slide. Then I also want to talk a little bit about neurotransmitters. So I've got serotonin and norepinephrine on here, and systems involved in processing pain and anxiety and depression all utilize these same neurotransmitters. Increases in noradrenaline is thought to be beneficial to mood and mental health, and I'll talk about this in just a few slides. But SNRIs, which is type of antidepressants, are thought to have some analgesic effects because of this shared relationship. However, it's not the same as improving pain via treating depression. Rather, the crossing pathways of shared neurotransmitters create pleiotropic effects of the same drugs. And then the last link I wanted to talk about in this presentation, although I do have more mentioned in my written essay, is about sleep. So this is a really important link because poor mental health and increased pain both lead to impaired sleep. However, having worsened sleep worsens pain and increases flare-ups, as well as spontaneous pain episodes and hyperalgesia. It also increases anxiety and overall poor mental well-being. Pain symptoms are particularly linked to poor mental health outcomes when sleep problems are involved. And this is another example of like a downward spiral, as having increased pain and more poor mental health also increases worsened sleep experiences. And this may be because the processing of sleep, like the pathways I mentioned earlier, are quite closely related to the ones that process pain, anxiety, and depression. So I just wanted to talk about a little bit about supporting mental health and well-being. So I've got on here about, it's a very broad figure, but between 2 and 61% of patients have depression, between 1 and 10% have anxiety. However, generally these two are treated separately in the NHS, and there's a general need for like stronger communication and linking between these two services so that the person is treated as a whole and not two individual conditions. And then clinically, mental health can be supported with CBT therapies, the aim being to change behaviour that exacerbates catastrophic thinking, suffering and disability. However, this does not directly treat the pain and mental health problem, and CBT has generally been found useful in control scenarios. However, it's not been replicable in general practice, and as many as 50% of patients found no benefit in undergoing CBT. But this may more be due to the limited access to CBT trained specialists who can provide individualised treatment, and as well as the overstretching of staff who provide these treatments. And then something that was regularly mentioned as being positive in the accounts I read were support groups. It's about providing space to share common experiences, expertise and motivation. And this is to help reduce the isolation experience from having a chronic pain condition. However, there are a few barriers in this as well that prevent regular attendance, such as it being unavailable in areas of the country or flare-ups in the patient's condition and preventing them from going every week. And then the last thing I wanted to talk about was antidepressants, because I thought this was really interesting. So I talked a little bit about shared natures of certain neurotransmitters, serotonin and norepinephrine, and some studies I read found that there may be pain relieving effects in the use of antidepressants, specifically SNRIs and TCAs. SSRIs did not appear to be as useful from what I read, and some of the effects included reducing allodynia, hyperalgesia, and affective comorbidities such as depression. Although I should also mention that negative side effects have to be considered, and it was found to have limited efficacy in certain chronic pain disorders such as neuropathic pain and fibromyalgia. And it should also be mentioned that because chronic pain is so individual to the patient, even the better evidence antidepressants did not work for every single patient who was diagnosed with the same condition. So that means there's no guaranteed effective treatment with every medication, and it's something that needs to be explored more. So in conclusion, I've given a very brief talk about some of the links that exist between chronic pain and mental health. There's a lot more than even what I could have written about in my essay, let alone discussed in this presentation. And in general, the multidimensional nature of chronic pain must be considered when treating comorbid anxiety and depression, and keeping good mental health is very important in reducing the impact and intensity of chronic pain. Mental health can be supported via psychological and pharmaceutical therapies, and it's very important to acknowledge the patient's expertise in the management of their own condition. Thank you so much for listening.